All right. Thank you for having me today. I'm Marielena Cid, diabetes, certified diabetes care and education specialist working at Eisenhower for 14 years now. And I am passionate about diabetes and spreading the word and trying to help people to prevent or delay diabetes or manage it well to prevent complications. Today, I'm going to talk about once you get diagnosed with diabetes, then what happens? What is the next step? So I had really good information about updates on new medications that also help with weight loss, which is one of the main things that people with diabetes need to do, lose some weight, and also preventing complications. I'll be happy to share. Hopefully I can answer everyone's questions at the end, but you can always email me. So please get my email, follow up with me if you have any questions or need any help afterwards. I'm always happy to help with anything or answer any more questions. So here is my phone number and my email, and we're going to get started. So what do I do after I get diagnosed with diabetes? What will be the next step? So first, let's talk a little bit about the recent statistics from 2021. So diabetes is on the rise. Every 2 years, we come up with the new statistics, and it is increasing fast. What doesn't increase fast is the number of endocrinologists or diabetes educators. So as we get more people with prediabetes or diabetes, we struggle on trying to get help to these millions of people. So now we went up to 37.3 million people with diabetes in this last results from 34 million. Diagnosed are 28.7 million. 8.5 million are not diagnosed. That means they don't even know they have diabetes. So they could be walking around with very high blood glucose and not know it. They may not have any symptoms. Also, the prediabetes went up from 92 million to 96 million over the age of 18. So 38% of the population in the US now has prediabetes. And 65 years and older, 26.4 million people have prediabetes. And that's really the time that people have to make a lifestyle change or do something about it to prevent or delay getting type 2 diabetes. So we want to target those 96 million people with prediabetes. So hopefully they can prevent or delay getting type 2. The ones that have diabetes, 37.3 million, the goal is to help them manage it well, keep their numbers in their target in the range, and hopefully they do well and prevent having some complications from it. The cost of having diabetes, it also keeps increasing. So the medical cost in the US just for diabetes management is up to $327 billion a year. And we're talking about billions just for diabetes, which is twice as high as for people who don't have diabetes. Having diabetes is extremely expensive, cost of medications, care in general, if it's caught early or late with complications. So it is very expensive. So we're gonna start a little bit on the types of diabetes. What are the different types? Most people only know about one. So we have different types of diabetes, and the first one is prediabetes. So if someone has type 2 diabetes, most likely they already have prediabetes. They were just never told, or they were not able to prevent getting type 2. But this is where you start. You start with prediabetes when diabetes sugars are a little elevated, but not very high, not high enough to get a diagnosis of diabetes. And so people may not even know there are no symptoms. All you know is that if the lab reports A1C shows that your sugar, the A1C was between 5.7 and 6.4, that's prediabetes. The normal is less than 5.6 or under 5.7. Fasting blood glucose, so your sugars fasting between 100 and 125. That's prediabetes. The normal is less than 100. So once you know you are in those ranges, okay, now I need to do something, or I'm going to go to diabetes sooner than later if I don't do anything. So changes are important there. We also have type 1, which is only 5 to 10% of the population of diabetes has type 1. And this is when the body doesn't produce insulin. It suddenly stops something that attacks the pancreas. It can be a flu, cold, it's autoimmune. So something triggers to stop the pancreas from releasing insulin. So they get a diagnosis and they may start injecting insulin immediately for the rest of their lives. They cannot get off insulin. But it's only 5 to 10% of the population in the US with type 1, which in this area, we are seeing a lot of people getting diagnosed with type 1 later in age in their 70s. It used to be diagnosed early, it used to be called juvenile, but now we're getting people in 50s, 60s, 70s getting a diagnosis of type 1 diabetes. And they do have to go on insulin and learn how to count their carbs and do all that. So it is very overwhelming at that age to be learning all those things, but they have to do it. Type 2 diabetes is the most common form of diabetes. About 95% of the population in the US has type 2 diabetes. And this means that the body is not using insulin that you're still producing properly. So it's not working well and sugars are still going up, but you're still producing insulin. And so making some changes, lifestyle changes can help make that insulin work better. And it can help you prevent delay in getting insulin. That oral medications may work, and just physical activity and the diet can really help you keep your sugars in range for a while. But like I said, it's a chronic progressive disease. It's going to keep advancing. So we have to keep up advancing the treatments and the lifestyle changes too. So it's reviewing with the physician what's going on with my diabetes. Is everything working in control? We also had gestational diabetes because, as you know now, we have at Eisenhower the birthing center. So we're delivering a lot of babies. We deliver over 1,000 babies in less than a year. And so now we are doing what we call the Sweet Success program for those women during the pregnancy now also are getting gestational diabetes. And we help them get their sugars under control. It's very strict to get their numbers under the range. It's different parameters than diabetes, type 2 diabetes. But we have to work really hard with them through the entire pregnancy to help them get their sugars under control. And then diabetes may go away as soon as they have the baby. But they do have a high risk of getting type 2 diabetes within 5 years of having the baby. And some of them may not be able to get rid of the diabetes when they have the baby, so they get diagnosed during the pregnancy with type 2 or type 1 diabetes. And they may need insulin during the pregnancy, and we help manage and get their sugars under control, like I said, until delivery. Then they're out of here, they're done with us. And we're seeing a lot of women coming in with gestational diabetes. And we also have the diabetes from other causes, and some can be induced by drugs, by medications, such as the cortisone injections, prednisone. So steroid medications can make sugars go very high, where people end up getting induced diabetes because of that. But they still need to manage the diabetes. It's still part of getting that sugar under control. Other treatments can be HIV, AIDS medications. When they're going through cancer treatments, their sugars, certain antibiotics can also cause sugars to go high. So after organ transplants, we're seeing more and more people with transplants that they get on high doses of steroids or anti-rejection drugs. So we are always monitoring that sugar. And today I'm going to tell you a little bit about all the ways we're using to manage and monitor sugar. So it's getting a lot better. So the first thing that I will do if I was diagnosed with diabetes, which I don't have it yet, knocking on wood, the first thing I will do is know how I got diagnosed with diabetes. Because the doctor may tell you that you cannot retain everything they tell you at that visit. So I will ask my doctor, what is my A1C, to know exactly where I am. If you look at this chart from the bottom up, we're going to start with the A1C. So the normal is below 5.7. So if you're under 5.6 A1C, you're good, it's normal. You're getting on the high side though. So I will work a little bit to get it lower. But once it is in the 5.7 to 6.4 range, I'm in pre-diabetes. I know that if I get to that 6.5, I am going to get a diagnosis of diabetes. And it changes completely, then I have diabetes for the rest of my life. So I need to know, where am I starting with the A1C? Am I getting closer to the 6.5, or am I on the closer lower 5.5 range? What do I need to do? And also the fasting glucose, normal is less than 100. If I'm fasting, if I go to the lab, I need to be under 100. So if I'm in the 99, I'm like, okay, I'm already on the higher end of that, but it's still normal. But once I hit 100, it's pre-diabetes. 101 to 100 to 125 fasting is pre-diabetes. And so if I get 126 fasting on 2 different occasions at the lab, I can get a diagnosis of diabetes that way also, no matter what the A1C is. But my fasting glucose cannot be more than 126 on 2 different occasions, so I get diagnosed with diabetes. The other way is also the glucose tolerance test. Normal is less than 140. So I go to the lab fasting. They check my glucose. They give me to drink about 75 grams of glucose, and then they're going to check my sugars every 30 minutes for 2 hours. So if at 2 hours I'm between 140 and 199, I'm in pre-diabetes. If I'm still under 140 at 2 hours, I'm good. I don't have diabetes or pre-diabetes. But at 2 hours, between 140 and 199 is pre-diabetes, or 200 at 2 hours, a diagnosis for diabetes for sure. And then we also can do a random glucose tolerance test where a random glucose test where people eat before they go to the lab, and they just show up to the lab, they draw their labs, and their sugar shows that 200 or higher. That's a random test, so they can get diagnosed with diabetes that way, for sure. And so there are different ways. So you want to find out from your physician, how did I get diagnosed? Where is my A1C? What is my fasting glucose? If you were not fasting when you went to the lab, you need to say that I wasn't fasting, because we always need to know if it was fasting or not. But diabetes is the 7th leading cause of death in the US. But this is underreported. They don't report that the person passed away because of diabetes. When they get admitted to the hospital, they're usually admitted through by a complication from it. They came in with a heart attack or a stroke, amputation or something else, and they passed. They're not going to say the person died from diabetes. That's why it's the 7th leading cause of death. So it's not very accurate, right? So another thing that you want to do is, what if your labs are normal? What if everything is good? Everything is normal? Then if you have any of the symptoms, if you're peeing a lot, constantly, you're drinking a lot of fluids, anything you can find, and I'm talking about gallons of water or juice, anything you can find, you're always thirsty. You're losing weight suddenly fast without doing any exercise or physical, any weight loss plan. That's never good if you're losing weight like that. And if you're hungry all the time, if you have blurriness, you may have wounds that are not healing, you just feel very tired, very dry skin, infections that keep coming, even though they treat them with antibiotics, you keep getting, like, I'm talking about a UTI, urinary tract infection, that keeps coming back and keeps coming back. And that's sometimes how we catch diabetes. We are like, when like a woman tells me, I keep having this UTIs, or a man, I would say, have them check your sugar. And for sure, it's always very high. So they do have diabetes. So I will always report any of the symptoms here. And a lot of people can diagnose themselves because they go and Google the symptoms and they have all of the symptoms. And then they go to the doctor and say, I have diabetes, I have all these symptoms. So we need to treat this immediately. So We'll start with some lifestyle changes, some tips on what can you do to get your numbers down once you have a diagnosis of prediabetes or diabetes. And we want to look at first physical activity. How physical are you? And I'm not talking about going to the gym and be on the treadmill all the time, sweating there for hours and hours, running or doing something strenuous. Is how active are you? Are you moving? Are you walking? You don't have to be doing these exercises, but how much are you moving? The recommendation is 150 minutes a week. If you spread it out however you want, as long as you get those 150 minutes physical activity, just by going for a walk, taking the dog for a walk, anything that is moving. And then twice a week, do some resistance exercises is the recommendation, so that as we get older, we're losing a lot of muscle, but if we stay active and we're doing some resistance, we are preventing the waste, the muscle waste. So we want to make sure we don't get all flabby and increase resistance at least twice a week. And so we will start with that, evaluating how much am I physically active daily or weekly. And then weight loss is the big one. If someone really needs to lose weight, where do I start? What kind of plan do I need to do to lose weight? So we want to make sure that if someone has diabetes, if they start losing weight, their insulin that they're still producing, they're more sensitive to it. So that insulin is going to start working a lot better and starts lowering their sugars, because they're physically moving and they're losing weight, and they become more sensitive to it. So that's why we always ask, you need to start exercising, but we need to explain how that exercise is going to be a benefit for diabetes and help you lower your sugars. The next one is a big one. Everyone wants to know about what can I eat? What kinds of foods I need to stop eating? And a healthy diet is crucial for managing diabetes, and we want to evaluate what are you eating, what types of foods do you like, and but one thing we cannot do is completely cut the carbohydrates out of our diet, because it's a critical component. We need carbohydrates for energy. They are going to break into sugar, so we need that sugar for energy. So we don't want to eliminate them completely, but we can maybe look at the amount that we're having at each meal, and then what types of carbohydrates we're eating. So people always come to us. Some people don't want to come to us because they're afraid we're going to take food away, that we're going to tell them you cannot eat these foods anymore. And that's not what we're going to do. We're going to evaluate to see how they eat, what kinds of foods they like, and help them balance that so that their sugar stays controlled. It doesn't spike as much after the meals. So we want to monitor the amounts, if they're having snacks and how many meals a day, along with physical activity and everything else that we talked about. So carbohydrates and diabetes management, I'll start by saying that there is no diabetic diet. And I know physicians, when they put a referral to us, they say diabetic diet. And so we really want to know how much of these carbohydrates you are consuming, because that is going to tell us how your sugar is after the meals. And sometimes just getting the carbohydrate in a balance and the right portion, your sugars come down. So you don't have to really start on medication. So you really don't need to start on insulin. And so just changing that meal plan, it will help you bring your sugars down. So that we start with that, with the food. And monitoring the intake, the amounts, the portions, the balance of the meal, it will help you really get your sugars under control. And then the types of carbohydrates, how does your sugar respond to the type of carbohydrate that you like? So reducing the amounts of sugars is it will be very helpful to manage if you have symptoms, but also to help you prevent a drop on your blood sugars or a spike in your blood sugars. So that will determine where are you in the range. And I'm going to talk later about the range where you should be. So I would like everyone to take notes so that you know what you're looking for when you're checking your sugars, if you are. And if you're not checking, you may want to start checking just to keep an eye on it. But having your sugars in the normal range is going to help you prevent the serious complications from diabetes. Also, we recommend do not skip meals. This seems like a simple way to, I just stop eating and then I start losing weight, and then my weight, my sugar is going to be in control if I don't eat anything. And that's not going to happen. We have a lot of people that wake up and they say, my sugar was so high, and now I'm not going to eat because my sugar is going to go up. And then they find out later that their sugar is still very high and they didn't eat anything all day. Our liver is storing extra glucose, so it's also dumping a lot of glucose. And if we don't eat, it's going to release that glucose. So might as well eat something to help to stop the liver from delivering too much sugar, to keep it in control, to put it to sleep. That's one of the reasons too we put you on metformin, to help to get your liver to release the amount of sugar that is releasing, to help you get your fasting glucose down. So we start on metformin. But having a consistent supply of carbohydrate in the bloodstream is what we're looking for, so that you don't become too high or too low. You want to stay within the range. So we'll talk a little bit about balancing your plate. And this is talking about balancing with healthy fats, having the right calories, right amount of carbohydrates, vegetables. Try the My Plate method. It's a very easy way of starting a meal plan without having to take food away. And so you're able to eat, but you want to look at what's on that plate. So I'm gonna show you a couple of plates that what it looks when it's balanced. So we want to look at the portions. The American Diabetes Association recommends to have half of your plate fruits and vegetables, mostly vegetables, because they're low in carbohydrate. And I'm talking about non-starchy vegetables. A quarter of the plate will be your starches, carbohydrates, whole grains, and then the other quarter of the plate should be protein. So that will be the balance. If you look at this picture, you can see the all plate portion. It was the opposite. So we have half of the plate carbohydrates, so that was sugar. And then the other half, maybe a little bit of vegetable and a protein. So now the recommendation is half of the plate vegetable, a little bit of carbohydrate, and a little bit of protein. So then you have to know, what are the carbohydrates, what are the proteins, how do I balance this with the foods that I like? So when you come to see us, or you come and see the dietitians, then that's what they can look at into, what types of foods do you like, and go more in depth in nutrition. But this is a simple way of just starting to look at your plate and evaluating what you like. So this is what it looks like, half of the plate, vegetables, starches, and proteins. To have that balance, your sugar will stay more in the control and the target range. If you start with that, you do want to cut back on certain red flag foods that are not very healthy, which is the sugary sweets. This is not something that you necessarily need to cut out of your diet completely. You can have them, but evaluate how often are you having these foods, right? So if it's every day, all the time, then obviously it's not going to be good for your diabetes, but doesn't mean you cannot have them. Once in a while should be okay. So just be careful with those, because you'll see also when you check your sugars, how much they affect you, how much they just spike. And so you want to treat yourself with moderation. If you want to have dessert, one tip I always give people is, if you go out to dinner, people go out to eat all the time, and you do want to have dessert, look at your plate. What did you order? Maybe you want to borrow some of that carbohydrate on your plate. So you can have your steak and your salad, and then you can have the dessert as part of the carbohydrate. So you're not having a carbohydrate in the plate plus a steak and the salad plus a dessert. So that's another way of borrowing carbohydrates from your dinner, so that you can have that dessert that you want so much. So that will be a way of doing that, trading something a little bit. And then another thing, the last one here, is the fiber. We don't eat enough fiber. Recommended is 30 grams of fiber to 35 grams a day. And most people do not even eat half of that. And fiber is very important. It helps you not only to feel full longer, but it also helps to get your sugar more in the control range and the balance. So it assists with the weight loss also. And it's in a lot of these foods that you can find fibers. People also buy the fiber powders or pills and put them on the food. Anyway, you can add fiber. Reading the label, see how much fiber is on the portion, which usually is very low amount on the portions. But you want to get things that are high in fiber. That will really help you get your sugars more in control and weight loss because you feel full longer, you're not as hungry, and you eat less. So now I'm going to jump. I really wanted to talk about preventing diabetes complications. We don't talk a lot about diabetes complications. We never mean to scare people about it, that this is going to happen. But a lot of people don't know that this is part of the diabetes, and those complications can be prevented. So it doesn't have to happen. Unfortunately, we see a lot in the hospital, especially amputations. But you can help reduce the risk, the seriousness of diabetes-related complications. If blood pressure stays controlled, you reduce the blood pressure, you can decrease the risk for heart disease and strokes by 12 to 27%. Also, the progression of kidney disease, your kidneys, 30% to 70%. So blood pressure, high blood pressure is not good with diabetes. So that's something that you need to be monitoring once you get a diagnosis. Where is my blood pressure and what should it be? You may want to ask your doctor, or if you have a cardiologist, ask, what should my blood pressure be? Because I have diabetes and they may want a different range. Cholesterol management can reduce cardiovascular complications by 20 to 50%. That's why we start on statins and we're monitoring it. What are you eating? Are you physically active? Is your cholesterol, triglycerides, and range? And then regular eye exams. Get a diagnosis of diabetes, get an eye exam immediately, and then every year after that, because that's going to help you prevent up to 90% of diabetes-related blindness. Because you don't know how long you have diabetes from the time you were diagnosed. Who knows how many years you already have the high elevated sugars that is already caused damage on the blood vessels on your eyes. So you want to get an eye exam with an ophthalmologist. You want to tell them that you have diabetes, so they do a very thorough assessment on you. It's different than a person that doesn't have diabetes. And they can really look dilation on the back of the eyes if there is any damage already. And then regular foot exams and patient education could prevent up to 85% of diabetes-related amputations. Just a simple education on check your feet. What do you see on your feet? Are you just looking at them every day? It can really help you prevent a amputation. So diabetic neuropathy is one of the big ones for diabetes. If you have it, you know what I'm talking about. It's painful. Is your nerves are getting damaged from having high blood sugars for a long time. They may be burning. It may feel like you have needles stuck on your feet. If you have sensation, you may not have any sensation. You don't feel anything. You could be walking around with a nail stuck on your foot and don't even know it. You don't feel it. Doesn't hurt. It's normal. That is the nerve damage that is happening from elevated blood sugars. So that's why we stress a lot, checking their feet and not walking barefoot with diabetes. And like I said, we do see a lot of amputations at the hospital, unfortunately, toes, feet, legs. And unfortunately, by the time a person comes to the hospital, to the ER, when they have a wound or a blister, something that got infected, a toenail, something that may be minor for a person without diabetes, for a person with diabetes, it's very serious. And so they may try to write it out at home. They keep watching it and it's changing color, or they try other treatments over the counter. So by the time they go to the ER, they may have necrotic tissue. It's already black, dead. We may or may not be able to save the toe or the foot. So you want to go to the ER. You want to go to the doctor right away as soon as you see anything on your feet, so they can check and do the proper, if you need antibiotics, especially if your sugars are very high, it does not help you to heal well or fast. So we want to make sure you're getting the right treatments. You can prevent an amputation. Diabetic retinopathy. This is what you get the eye exam at the diagnosis and every year, because this is a normal eye. This is an eye that has a bleeding blood vessels that is very tiny microvascular vessels that are high blood sugar is damaging, is rubbing on them, is damaging, but they may not be able to see it unless they dilate your eyes. So if you are having blurriness like this picture here, this normal picture, and then this is when they're seeing these black spots here is when people are having already blind, they're going blind. So they can't see and they're not going to be able to see. And then you may need to see the ophthalmologist at least every 3 months or whenever they ask you to come and see them. Because of diabetic retinopathy, there is already some damage. So they need to, if they catch this early, then you have a good chance of not going blind, right? Also diabetic nephropathy, kidney damage. If we catch that early, it's common to have a reduction in function of your kidneys as we get older. But if it's coming down fast, then we don't want to wait till we are getting dialysis. If they refer you to a nephrologist, a specialist for kidneys, we're watching with the endocrinologist to make sure your sugars are in good control, that you're on the right medications. Dialysis is 3 times a week, every other day. You're there for 3, 4, 5 hours, and they have to get your blood out of your body, clean it up, and return it, because the kidneys are not able to filter any toxins out of it. So they need to filter that and get all the fluid out that you don't need, and then return it back. And you have to do that every, like I said, Mondays, Wednesdays, Fridays, or Tuesday, Thursday, Saturday, or an emergency dialysis and the ER anytime. Heart attacks are very increased. The risk with diabetes increases 2 to 4 times higher risk for a heart attack. And we're looking at blood clots that blocks up an artery on the heart and doesn't let blood flow. So the muscle in the heart starts dying. And that's where you start having chest pain, or you start having symptoms. And is it a heart attack? What is it? So you always want to call 911 and go immediately to the hospital, because they need to make sure. It's better to check and make sure that it's not really a heart attack than to have one and be too late, because this is urgent. This is an emergency. They need to stop that. They need to see if they can get rid of the blood clot and then treat you. And then you go home, and then you may have to go through cardiac rehab to get your heart healthy again and make you exercise and get it back to functioning to optimal level. But heart attacks are very high risk with diabetes. Strokes also are very high risk in diabetes, and we're looking at blood clots in the brain. Something is getting blocked. You may lose the balance. You may start having blurriness. Side of the face that droops. You have very slurry speech. You can't keep an arm up. It drops. So there's weakness on one side of the body, and the time is crucial to call 911. You don't want to drive yourself to the hospital. This is an emergency. Strokes are common, are higher risk than diabetes. So we want to make sure that everything is getting monitored. So these are serious complications from diabetes. The other one, gum disease and heart disease. And people don't think about this, but gingivitis or gum disease are higher risk than people with diabetes. And we had a patient once that he had a bacteria in the heart, and the cardiologist they didn't understand how that bacteria was on the heart when that's a bacteria that is common in the mouth. So I said to them, well, I said, this patient has diabetes. They put a consult for me. So I went to see the patient. I said, this patient has diabetes. Have you asked them to open the mouth? Have you asked him? I said, tell him to open the mouth. And it was Spanish speaking. So I asked him to open the mouth. And it had infection all over his mouth. Black, ugly. And so that bacteria got into the heart that way. And then people can die from that, because once it travels is a serious complication that they could die from it. If aggressive treatment that they need with antibiotics, a blockage I mean, there's so many things, but we want to catch that infection in the mouth quickly and treat it immediately, aggressively, to get rid of it and hopefully prevent it from getting into the bloodstream on the system, the bloodstream. So those are some of the complications from diabetes that, like I said, everything is preventable. What do you think will be the number one way to prevent those complications? And I know you all know the answer. Getting the blood sugars and the time and the right number at the right target. The good news with this too, you have now more choices. We do have diabetes medications that are really good. The problem is that they're very expensive and they may or may not be covered by your insurance. I know Medicare takes a long time to cover anything, but they're getting better at covering. So these are newer medications like called GLP-1 receptor agonist. So these medications are injected. Some of them are injected weekly. They are diabetes medications. They're not insulin. And they help control your sugars really better without having to go on insulin. And you do an injection once a week. And they also help with the weight loss. We cannot promote these medications as a weight loss. It's diabetes medication. But we want everyone with diabetes, if possible, to go on these medications because they're really going to help get the sugars under control plus weight loss. How do they do that? Slows gastric emptying. So you eat, you feel full longer. You're not as hungry. You're eating less food. Your food stays longer in your belly. And then, so you increase the satiety. So you're not going to be as hungry. You're not going to be eating as much. And then the weight loss starts coming up. Ozempic is one of those good ones that they have done a lot of studies, and we have a lot of people on them and losing a lot of weight. Trulicity. Victoza is injected once a day, but all the other three are injected once a week. So those are easier, better medications. And then Rybelsus, this oral medication, is the new one. It's the same as Ozempic, but in a tablet instead of an injection. So we have more choices there. We also have this new one. This one just got approved by the FDA a few weeks ago. So it's a brand new medication, Mounjaro. It's also injected once a week, for diabetes, for type 2 diabetes. It's approved. And they did studies where the weight loss was huge. It was even better than doing gastric bypass. So maintaining the weight loss and all that, that's why these medications work really well. Like I said, the problem is that they're very expensive when they first come out. So we have to wait a little bit and hopefully insurances start getting better at covering them for everybody so that you can use them. Because they're not only good for weight loss, they're also helping to keep, protect your heart, your kidneys for heart failure patients. Cardiologists are prescribing these medications now, even for their patients if they don't have diabetes, because of the studies that they have done for these medications and how they are helping with weight loss by preventing heart disease in heart failure and kidney patients. So these are really good medications. They do have some side effects. And I tell people, if we read the side effects, we're never going to take anything. So I don't read side effects until I start having something. I'll go and read it. Oh, is this part of this medication that I just started? But it is one thing you really need to look for is, does the thyroid tumors run in the family? If you start a new medication, you need to report immediately to a physician that put you on the medication if you're having any side effects. One most common side effects is nausea. Some people may vomit. I rarely hear people vomiting, but nausea is one of those. But it's only the first few weeks while your body's getting used to the medication, and you start at the lowest dose for a week, and then we increase it a little bit more for another week until you are at the right dose that we want you to stay at. And then we're monitoring your sugars, and then if you're having weight loss, if everything is good, then you stay at that dose. We don't have to keep increasing. But this one in the studies had an increased amount of weight loss. And you start with 5 milligrams, 10, and then the goal is to go to 15. If you're doing well at 10, then you stay at 10. It did much better in the study than Ozempic with 1 milligram once a week. So those are newer medications that are coming for weight loss. These are 2 medications that got approved that are not for diabetes. These are for anyone that wants to lose weight. The other ones are for diabetes. You have to have diabetes to be on them. But this one, Saxenda, Wegovy, are approved for weight loss. And Saxenda is the same as Victoza, which is a daily injection for diabetes. It's the same medication, but it's approved. This one is approved for people that don't have diabetes. So if the doctors prescribe it, like I say, you start at the lowest dose. You see here week 1, 0.6 milligrams. Then you inject, then you go week 2.2, and then you will go to 0.8, 1.8, and then so on until you get the 3 milligram dose. So the pen will last about 6 days once you get to the 3 milligrams. And then Wegovy, same. It's weekly medications that you inject, and anyone that wants to lose weight and wants to try them, discuss it with the physician to see if you insurance covers them, and monitor for weight loss. Obviously, all these medications are going to say that with a healthy diet and physical activity, right? There is nothing magic about these medications that you're just gonna lose the weight and continue the same lifestyle. So we do want you to watch still a healthy diet and be physically active while you are with these medications and help change the lifestyle. These ones are oral medications that also are for diabetes, and they do help also just to stabilize your sugar and help with a little bit of the weight loss. These ones are so that you pee out sugar in the urine. So when you're taking these medications, we need to know that if they do an urine test and you have sugar in the urine, doesn't mean your sugar is very high and that we're going to rush and put you medications to help you lower your sugar. They need to know that you are in these medications and that it's making you get rid of that extra sugar through the urine. So you're not reabsorbing, your kidneys are not reabsorbing the sugar that is supposed to be going out. So you pee a lot. One of the things you have to do here is clean really well after you urinate, because that sugar is coming out in the urine. So if you don't clean well, and this is for men and women, you can end up getting infections. So you have to rinse really well because that will be a great source of causing an infection if that sugar stays there. And so a significant amount of sugar that you pee out a day. And so that helps also with the weight loss. But your sugars come down and your blood pressure comes down. And so we really have to do education when someone starts on these medications. And then the last part here is monitoring. You know you have diabetes now. You need to start checking and look and see where you are with your sugars. If I'm going to start making some changes, is it working? How much I need to be exercising? How much is it lowering my sugar? What I'm eating, is that helping lower my sugar? Are my meals are still too large? Is my sugar still spiking after the meal? So you really want to be monitoring. Traditional way is a glucose meter. You have to do a finger stick, right? Maybe once a day or twice a day. Whatever the insurance approves for you to get test strips are the expensive part here, those little tiny things. And so they may allow you to check once or twice a day. And you put it in the meter, you do a finger stick, and you apply a drop of blood in the strip, and then in 5 seconds, it's going to tell you what your sugar is, right? What we're using a lot lately is the continuous glucose monitors. So the Libre 2, you stick the sensor on the back of the arm, one click, you activate the sensor with the reader or the app on the phone, and it goes through a 1-hour warm-up. And then after that hour, you start scanning to look at your sugars. And you have it there for 14 days. You scan it as many times as you want. We normally recommend that you scan before each meal and at 2 hours after the meals, at bedtime. You cannot go 8 hours without scanning because you lose all that data that is collected into the transmitter. So you want to scan before you eat, 2 hours after you eat, at bedtime, as soon as you wake up in the morning, and try to get as much information. We want to evaluate to see if your medications are working. If you are injecting insulin, Medicare covers the sensors. And we can tell you all about it. If you come to see us, then we'll get you all set up. We get you to try one, and then you get started on getting them at home, and we train you on how to put it on yourself. You change it every 14 days. The Libre 3 just got approved a couple of weeks ago. They reduced the size by 70%. So now the size of a penny. It's only going to come out with the app on the phone. So you only scan, you don't need to scan it anymore. It will automatically transmit the glucose to the app every 5 minutes. So that's a big change. No more scanning, but you cannot use the reader to scan or to get the sugars on the reader. It has to go directly to just the app on the phone. So that's a big change. And it's 14 days, so you need 2 sensors per month. You can, your insurances, most insurances cover them now. Medicare, like I said, as long as you're injecting insulin, even if it's once a day, you qualify for them. Or you want to purchase them cash, you just need a prescription from your doctor. Also, you can go and pay cash for them at the pharmacy. The Dexcom G6 is the G6 is the one we have. That one you insert it. It goes through a 2-hour warm-up. And then it automatically starts transmitting the sugars to the app every 5 minutes. If that sensor is good for 10 days, the transmitter is good for 90 days. So you have to change that transmitter every 90 days. The G7 is coming up pretty soon. That we were told that will come out early summer. So anytime. And this is going to be a huge change compared to this one, because this is a little click. They eliminated having to change the transmitter, so it's now integrated. It will be 1 click to insert it, and they reduced the warm-up time from 2 hours to 30 minutes. So after that 30-minute, automatically you see your sugars on your phone or this the receiver instead of doing a finger stick. So this one communicates directly with the insulin pumps also to be able to adjust the insulin on the pump based on that sugar that is being sent every 5 minutes. So those are great devices. The Dexcom is approved as the most accurate sensor and is pretty close to your blood sugar. But just keep in mind that the sensor is reading interstitial glucose. If you do a finger stick, you're doing blood glucose, so it's not going to be the same. People want to see the same number from the finger stick and from the scan on the sensor. It's not going to be the same, but it should not be crazy difference between the two. And I'm talking about 50, 80 points between the blood and the sensor. If it's 20 points, 10 points difference, that's good. It's acceptable. People are using them to dose insulin, so they're very safe, pretty close accuracy. So we have those. So what are you looking for when you scan or you do a finger stick is to make sure, if you look down here, if you have diabetes, your sugar should be between 80 and 130 before meals, less than 180 at 2 hours after the meals. If you don't have diabetes, you want to be less than 100 before a meal, less than 140 at 2 hours after the meal, right? So that's the difference. And the A1C, you want it less than 7% if you have diabetes to be a target at the range. If it's over 7%, that means you're it's uncontrolled diabetes. That's what they call it. So it's not in the range. And we want to look up a little bit more on lifestyle changes, or do we need to increase medications a little bit to bring it down? But you want to keep an eye on it that it stays under 7%. The higher over 7%, again, the higher risk for complications from diabetes, because that means sugar is higher. So an A1C of 7% means that your sugar has been ranging for the last 3 months around 154 every day for the past 3 months. That's what it means. So we don't want to go higher than that. If you're having an average or your sugar under 150 for 2 weeks, the A1C, getting your sugars under 150, that's pretty good target. And then you want to look at your blood pressure, that you are under 140 over 90, or if you don't have any other complications or any other things, diabetes is pretty much in control, then you want to be under 130 over 80. So that's why you want to ask your physician, what is your target for blood pressure? Because the blood pressure, like I said, is affecting your eyes, your kidneys, and everything. Cholesterol, also, where is your cholesterol? Are you taking medications for cholesterol? And if not, why not if you need it. Side effects, report immediately so they can change the medications. But we want to make sure that the cholesterol stays also within the range. You don't want to get blood clots or plaque on the arteries. And this is my last slide. So I gave you a lot of information in this past hour almost. And one of the things is that the key for diabetes management is diabetes education. You want to be able to get educated as much as you can about diabetes. It's a lot of information, and this information is constantly changing. Parameters, guidelines, devices, targets, all this stuff is changing a lot. And so we want to make sure that you stay updated. Medicare covers you to come to see us every year for annual follow-up visits to get you up to date on new devices, new medications, what's going on with your diabetes. Are you okay? Are you doing okay? You see the dietitian, you can see the diabetes educator, the nurses, and then we want to make sure you are taking advantage of those annual follow-ups covered by Medicare. And if you don't have Medicare, you have a separate private insurance. Also, once you call your insurance to see if they cover you, or when we schedule you, pre-registration verifies if you're covered. But we are able to help you, train you on anything that you need training on. And then in summary, everything that we discussed today, it is going to help you get your type 2 diabetes in control and help you prevent all those complications from it. One I did not mention is smoking and lifestyle change. If you smoke, that's a big no-no when you have diabetes. Quitting is not easy, probably one of the hardest addictions to quit, but you do want to consider quitting smoking if you do, once you have that diagnosis of diabetes. The other ones we discussed, so if you need any help with that, you have questions, I will open up now with them. I don't know that I can read the chat, but you have my email, my phone number to get in touch with me if something comes up or you need help, you get in trouble. Please do not hesitate to reach out. Do not wait too long. So I will open up now, Brett, for questions.
Great. Candace, if you want to go ahead and read the first couple of
sure.
questions.
Jeff wanted to know that, well, basically he said he knows that soda is not good in general, but where diabetes is concerned, is Diet Coke okay? And do artificial sweeteners have the same effect as sugar?
Yes, so great question. We get that question a lot. We do get a lot of people that like to drink soft drinks. And they said, I don't like Diet Coke. But if you have diabetes and you're drinking Coke, that is loaded with sugar. It's more than what you need in a meal, just sugar, and it's liquid. So it is going to spike a lot very fast, right? Plus the food. So you end up eating a lot of sugar. So when we mention, well, if you are not going to be able to quit drinking soda, it's better to go to diet because there is no carbohydrate, there is no sugar in the diet drink, although it's a choice. It's not that we're recommending that you start drinking diet, is that people say, well, I don't like diet, but making that switch takes time to get used to it. So it will be answering the question a lot better to be on a diet, taking a diet drink than a regular drink, based on the sugars and based on the damage that those sugars cause, that you're chasing it down, trying to bring it down afterwards. Was there a second part of the question that I?
Well, it was the artificial sweeteners have the same effect as sugar.
No, artificial sweeteners do not affect diabetes. We have never seen any study or anything. I haven't seen any patient that uses artificial sweeteners on their coffee or anything that gets their sugar up to spike.
Well, and I'm going to add to that because there's so many now natural sweeteners like sativa, or what is not sativa, like
Stevia.
Stevia. That's why I was
Splenda.
hooked on the pot thing.
Stevia.
I couldn't get sativa out of my head. Stevia, and those. So are those sweeteners? Do they spike?
No,
Okay.
those are better. They're not sugar. is artificial sweetener. So maybe 100 times sweeter than sugar. That's why you only need very little, but it's not going to spike anything on your sugars. It may cause, if a person has any other conditions, gastrointestinal, they may not be able to digest those, or they may have a lot of gas, or they may have other issues with it. But we had never seen the diabetes getting affected because of those artificial sweeteners.
And Alicia wanted to know, does salt affect diabetes?
Salt,
Salt,
yeah, salt does not affect the sugars, but it does affect heart disease, heart failure. If someone already has those problems, we do want you on a low sodium diet because the blood pressure will go even higher. So they may be on a restricted sodium diet, but it does not affect sugars, no.
Okay. And Lorenzo wanted to know, once you are on diabetes medication, do you still need to regulate what you eat?
Yes, the diabetes medication is gonna help you a little bit we're trying to get your sugars under control, but changing your diet, eating healthier, balanced, healthy meals, it is going to make a big difference. So you may not need as much medication, or you may be able to get off the medication. But never stop a medication without consulting with your doctor, because that may be a reason that your sugar is controlled now because your medication is at the right dose. Once you think, oh, I'm changing my lifestyle, I need to stop my medication, your sugar will go up again. And then you're going to have to start over to try to get it down. So yeah, but you may need, for type 2 diabetes, you may not need to be on medications. You may be able to get off medications, or you may be able to just at first manage it with lifestyle changes.
Okay, and Mary wanted to know how many carbs should be included in a meal.
Thank you for that question. I forgot. So for women, the recommendation is that whatever you are eating now, you may want to try to get it within 30 to 45 grams of carbohydrates per meal. If it's a snack, we want to keep it 15 grams or less, always with a protein or a healthy fat or a vegetable. So in a meal, remember, it's just the carbohydrate that she's asking for, but it's also getting your protein and your vegetables on that plate. So keeping a low carb or a normal range will be 30 to 45 grams for women, 45 grams to 60 grams for men per meal.
Okay, thank you, Marielena. And Jeff Miller, we have similar stuff here. My cholesterol med is doing a good job, except my triglycerides are high. And it might be partially a side effect of his HIV med. My doctor doesn't seem to think it's at a scary place, but his A1C just hit 6.5 for the first time.
8.5, the A1C?
6.5.
6.5. Oh, that's a good diagnosis for diabetes now with that 6.5. Triglycerides are going to be high also if the blood sugars are high. So the higher the blood sugar, you could have high triglycerides. So we may need to look into what is causing the blood sugar to go up and then see if we can still make it go down. But with a 6.5 A1C, you can get diagnosed with diabetes, unfortunately. But so yeah, we can you can try to see if you can see a dietitian to help you really get the right foods that can help you lower your cholesterol, your triglycerides, or medications. I think you said that it's already taking medications for cholesterol.
No, no. HIV meds.
Oh, HIV.
Oh yes, no, he is taking.
Mm-hmm.
Oh, my cholesterol med. You're right. Yes.
Yeah, and we need to look at the diet and what else can they do to help bring that down.